Hello everyone, I think it's just hit 7 o'clock. Can you all hear me? Yes, I've got some nods. I'm Elise Brogan. I'm the Derbyshire Education Network Clinical Lead. So I organise these 2 monthly education sessions. So thank you so much for all coming to join us tonight. Special thanks, obviously, to Dr. Matthew for giving up her time. So really, really kind of her to be here tonight. And we were just telling her, we've had so many people sign up. This is such a popular session. And I've been getting lots of messages saying, is this being recorded? So I'm sure you'll know, as you entered, it will have told you that this is being recorded.
Good evening. Those very kind words from Elise. I didn't realize this was going to be such a popular topic. It's making me all quite nervous. And I'm not very good at this virtual sort of, what shall I say, talks. Because I quite like to see my audience, and obviously the interaction is definitely much better experience, which I'm sure you'll all agree. Okay, so I'm one of the consultant gynecologists at Chesterfield Hospitals. So I've got 2 hats on, one as the cancer lead, gynae cancer lead, and I'm also a menopause specialist and trainer. So obviously, if there are people who are interested in training, you can by all means get in touch with the department, and then we can put you on the waiting list and get the training, which is it is kind of a little long-winded in the sense that there's quite a bit of information on the British Menopause Society where you can actually access in order to become a menopause specialist and then subsequently a trainer, but we'll come to that later. So the objective of the next 30 to 40 minutes is to empower GPs to undertake menopause consultations confidently and know when to refer to secondary care. Now, in order to get what I would like to actually, if I were actually delivering this talk face-to-face, would be to find out the audience when they qualified, because that's very important for the next slide, in the sense that were you a GP qualified pre-90 or pre-2000 or pre-2010 or post-2010. Now, I'm a consultant who's qualified pre-90, so cruising towards retirement. And therefore, I have gone through the entire history of HRT and where we are today. So how do we actually get ourselves empowered? First and foremost, what I would like to comment is, as GPs, you're all have got very effective decision-making skills. You've already dealt with significant number of complex problems, and where would menopause sit in this complexity is quite low. I would say probably in the 10th or 15th centile. So you're already empowered to be able to undertake menopause consultations confidently. Now, you have already indicated the drive to continuous learning throughout your career, and you have got significant analytical problem-solving abilities, and you take control of your own training. So already you are there. It's just that you need to tweak with some of the current information. Now, how would you do that? Essentially, if you are able to attend a British Menopause Society course, say too early, there are plenty of virtual courses. It costs about 120 to 150 quid. Which gives regular updates for GPs. And also, alternatively, I have seen that on the GP website also you have got certain sessions that you can update yourself. Then clearly getting into the engagement and reflective practice every time you see a patient and prescribe a HRT. As a teacher, I think you always learn. As I was just telling Elise, that today's talk is more of a win-win situation where I have learned a lot by preparing for this talk myself. Training juniors is always a good way of empowering yourself and learning more that will keep you engaged with the current information. And clearly, as I said, there may be already some pre-existing knowledge which probably needs replacing with the current evidence so that you become even more empowered in order to be able to undertake these consultations. So this is the reason why this particular slide is the reason why I asked, or if I were to have a face-to-face talk, would be to kind of identify who were the different cohort of consultants of GPs that I may be talking to. Now, if I go to pre-millennium history of HRT in the 1960s, it was introduced and thought to be revolutionary, and in 1965 it was first available in Britain. However, it was obviously expensive and it was thought to be mainly for the rich. So in the 1970s, that's what the concept was. But several products then appeared in the market and became more affordable and was obviously prescribed to a larger number of ladies. And in the 1990s, it was ever so popular. I remember when I entered Britain in the mid-90s, it was one of the medication to keep you youthful forever. However, since then, there was this Women's Health Initiative study that was conducted in the US, and then in the period between 2002 to 2004, there were some adverse comments that were made from the studies. And looking at the information that was provided, it said the HRT arm of the study prematurely was stopped in light of findings of safety issues with combined HRT, which showed a small increased risk of breast cancer, heart disease, stroke, and blood clots. So you can understand that how the media took it on and said it will kill you and therefore stop it. So it is in that early half of 2000 is when the adverse publicity went around, and that it just went on and hit the headlines, scary headlines. HRT is not for anybody because of the problems. However, by more studies and more information came along with the Million Women study, which said in 2007 it might be okay. And what it then said was, it showed, I'm just looking at the information that actually reading these new findings also show the additional benefits of HRT used for those initiating HRT in the 50 to 59 year group, or for those less than 10 years past the menopause, because it showed reduction in heart disease and no clear increase in risk from stroke, and a very small increase in breast cancer risk. So therefore, by 2007, it just started off saying it might be okay. And then more information came on that the right dose for the right woman at the right time and for the shortest time, that was what the 2012 period suggested. And then came the NICE guidance in 2015, kind of revolutionized all the several thoughts about HRT. And in 2016, the study showed that the breast cancer risk may be not as bad as we thought. And then in 2019 came the micronized progesterone, which clearly showed that it was breast neutral, or in other words, there was no particularly increased risk of using this sort of progesterone for HRT. As you know, progesterone is the culprit for increased risk of breast cancer. And then come 2020, it clearly said that the estrogen only HRT, in fact, even confers a small protective risk for breast cancer, though I don't entirely agree to that, and I don't counsel my patients along that lines. And there is a slightly increased risk of breast cancer with combined HRT, and there are some other benefits, which we'll come to in a bit. Now, I thought this slide would be quite useful. In 1900, the average age at menopause was 45 years, and so was the life expectancy. So no doctors ever knew about, or no patients knew what is menopause and what are the menopausal symptoms. The life expectancy of a female born in England in 2022 is currently considered to be 83 years, and an increase of 21 years in life expectancy compared to the birth when the queen was born. Now, currently, the average age of menopause in the UK is 51, and therefore you can see that a third of one's life is in the menopausal state. And currently in the UK, there are a third of the UK population is over 50 years of age. So you can see the magnitude of the problem that is there in front of us. Now, there is slight variation in the average age of menopause based on the race. The Black and the Asian population, they have hit menopause slightly earlier, and the average is about 48. Now, there has been significant shift in our social, economical, and technological environment. As you can see, there has been an IT jungle. In fact, the whole technology has changed, the media has changed. people's expectations have changed, and women are experiencing menopause are more likely to be employed, have multiple care roles, and they carry excess weight, unfortunately, do less physical activity and have medical comorbidities. And therefore, we have to take all these into consideration when we are going to prescribe patients HRT. And impact on the individual menopause experience is also very expansive. Now, is it worth appointing a woman around menopause? Yes, in the ideal world, if we have all the resources, it will be excellent to kind of offer all women around the age of 50 for a chat, because this forms a good opportunity to discuss obesity and metabolic syndrome, which itself is a big topic, and I'm sure any of the endocrinologists will be happy to go through that. And it's quite worth finding out the lipid profile and the insulin resistance and ways to tackle that. Cardiovascular disease risks, dementia, osteoporosis and arthritis, the cancer risks, mental health, and also the risk benefits of HRT. So what are the symptoms of menopause? Unfortunately, this overlaps significantly with a lot of other conditions. There are physical conditions here: headaches, palpitations, fatigue, joint pains, hot flushes, night sweats, bladder symptoms, vaginal atrophy, and the psychological symptoms such as a panic attack, memory loss, brain fog, irritability, low mood, depression, crying spells, low and absent libido. Now, always when we take a history, we should consider family history, comorbidities, the race, smoking, alcohol, and age at menarche. Now, clearly differential diagnosis, which you may be able to tell better than me, are the various conditions, the endocrinological conditions, thyroid functions, epilepsy, there are subclinical infections, some cancers, medications that they are on already, which can mimic some of these symptoms, autoimmune disorders, mental health, and clearly now it's a new concept, the long COVID, which is obviously relates to significant tiredness and fatigue. Now, how do we assess these symptoms? There are various questionnaires that are available, and in Chesterfield, for our patients, I have actually designed a questionnaire which actually will be available for you, because I have emailed Amy, who with a pack of information, in addition, including the slides, which are also available for you, and some fact sheets, which can add flesh to this talk. And in that is the menopause questionnaire. So you may want to take some of the information from there to make your own questionnaire, or you can follow the same questionnaire, which is not a problem, which obviously has a weighted scale of the symptoms, and starting from 0, where they don't experience any of the symptoms, to 3, where it's extremely being affected by these symptoms. The main thing that one would establish is how much of these symptoms are affecting your life at home, work, and socially. So here's the panacea for postmenopausal health. It's pretty self-explanatory. The stresses at work, and there's menopause at workplace is a big thing now, by the British Menopause Society, for the employers to recognize that menopause is a problem, just like how you would get maternity and leave. Clearly, reducing stress factors by engaging in stress management, avoidance of smoking, getting fit, eating a healthy diet, tackling the obesity, and clearly there is the HRT, and now the more fashionable thing is the testosterone supplementation. So lifestyle management, again, identifying triggers, exercise, weight management, stress management, and I suppose this would apply to any medical condition, I would think, and general preventative health, not only for menopause. And decision making. So how do we actually have a patient in front of us, and how do we make the right decision for the patient? So these are the questions that go through in your mind. And again, this is an overlap of these questions with any medical conditions. How bad are the symptoms? Will the pharmacological intervention help? Is the pharmacological intervention safe for this patient? How long should I be treating her? And is there anything else that can help this patient? So practical HR, practical prescribing. So the rationale, as you already know, but I'm just recapping it. If the lady is perimenopausal, she needs cyclical HRT. It's quite simple, very simple. Just if you remember this slide, if she is perimenopausal, she needs cyclical HRT. If she is postmenopausal, she requires only continuous HRT. If she does not have a uterus, she can have continuous estrogens. And there are some special situations where if a patient has got if one of the ladies has got a Mirena in situ, then clearly you change your HRT administration. Or if the patient already has had a hysterectomy, has got active endometriosis, and again, it's a different HRT that you give. So this is just a flow chart which clearly shows and easy to remember. Menopausal HRT, uterus intact, LMP less than a year, she is premenopausal, then you can give them a cyclical HRT. LMP over a year, then you can give them continuous HRT. Are they post-hysterectomy, then estrogen on its own, and tibolone has been added there, but I'll come to that in a minute. That was before testosterone became more in fashion. And if they have only vaginal symptoms, then they can easily get vaginal lubricants and moisturizers. And then clearly we have non-hormonal treatment, non-medications for these patients. So next, what we need to know is which hormones, which regime, which route, which dose. So certain pertinent slides. So which hormones, which regimen, which route, which dose. I've tried to simplify as much as possible. So which hormones? Very simple: estrogens, progestins, testosterone. And within the estrogens, you've got the conjugated ones. You've got the estradiol and estron or estriol. Now, clearly, there is no particular benefit of one over the other unless the patient tells you of some side effects or symptoms, in which case you may just want to try different ones. And coming to the progestins, you have got the derivatives, C19 derivatives, which is the norethistérone or the levonorgestrel. And I've teased it out differently only because I need to come to tell you what the side effects are for these. C21 are the medroxyprogesterone acetate and the dihydrogesterone. Now, between C19 and C21, the C19 progestins have got a higher androgenic effect. So they have more acne, more salt retaining properties, and therefore likely the patients are going to experience more bloatedness and so on. However, with the C21, it's less. So if the patient complains of some symptoms, then you've got that leeway to change the progestins or choose a HRT with a different progestin. So in the BNF, there's a list of all the HRTs that are available with what component in it, and it's also in the pack that is going to be distributed to you. Will have all the HRT preparations that are available in UK with what combination of medication is there on by the side, along with the brand name. Now, as I alluded to before, in 2019 came the micronized progesterone, and it's the utrogestan, which is micronized progesterone. And that is considered to be what is called the body identical HRT, body identical progesterone, and it's supposed to be breast neutral, and therefore it is becoming more and more popular. And until any other safety issue comes through, then clearly utrogestan seems to be the way forward. The only disadvantage with the micronized progesterone is that it's only available orally or vaginally. We do not have a transdermal route for the micronized progesterone. The drosperinone is a synthetic progesterone, which has got a significant anti-aldosterone properties. And of all the progestins, this is considered to be the least effect on bloatedness, or so therefore it's probably more popular if women are troubled with what you call premenstrual-like syndrome and they're given progestins or bloatedness. Right, so I have just made a little table here just to say how it's available. So micronized progesterone, as I said, is available orally or vaginally, in either in the isolated form or in the combined form, combined tablets, which has got estradiol with it, and that is a Bijuve. So that's probably if you're planning to give a lady oral combined HRT, which would be obviously in the postmenopausal group, because there it's not available in the cyclical way, then it is Bijuve would be a good option. Then progestin, the C21 progestins, which is a dihydrogesterone, it's there in the combined oral only. The norethisterone C19 is there in the combined. And the levonorgestrel, you can get it in the combined patches or in the Mirena. Now, norgestrel is a C21, but it's a lot less potent. So these are HRTs which contain these type of progestins, and the estrogen remains the same. It's there again only in the combined oral. And you can get medroxyprogestin acetate, which is a C21, which is oral, and then the drosperinone, which is in the combined oral content. So it's called Angelique, but it's not readily available in this country at the moment. So which route? Oral is convenient. It comes in calendar packs, and you can get it in cyclical and in continuous way. Transdermal has got less thrombotic effect and avoids first pass. Obviously, it wouldn't be particularly popular if the patient has got psoriasis or eczema, extensive psoriasis, eczema, or I've got some ladies who say that they swim a lot and they find patches are a bit of inconvenience. Then clearly you've got the intrauterine system, which is my preferred way of giving HRT, because it's in there for 4 years and alongside any estrogen via any route. Some people may not like it. Some ladies do not like the coil. They've heard horror stories, so that's not for them. And also clearly inserting it may not be that readily possible in the primary care setting, or there may be a waiting list, in which case you obviously have to tide over that period. Now, one thing I would like to point out is that if the Mirena is used for contraception, it's for 5 years. But if you're using it for HRT, then it is only 4 years. So the ladies have to make way around the end of the 3.5 year to 4 year mark to make sure that they change their Mirena if they wish to continue with the HRT. Now, implants are available, and I remember when I started my training in this country, there used to be an implant clinic in the NHS, and we used to insert estrogen implants to these patients, but it's not no longer available in the NHS. However, the problem with that is tachyphylaxis and some intermittent observation, and currently, as I said, it's not available. But the patients who are on the implants, they go by it and they will not accept any other route, to the point that they are prepared to pay privately to have these implants. Now, vaginal estrogens are, as I said, even if you're not giving them the combined HRT, it's perfectly safe to give patients. No progesterone is required, and they can even be given to patients who have got a history of breast cancer. So that may be something, an alternative which you can give for ladies in whom HRT is contraindicated. Now, estrogens, as you can see, are available as tablets of these, either as a 0.5, 1, or 2 milligram. You can look at the BNF and decide how much of estrogens you want to give the patient. So it starts with the lowest dose of 0.5, but that's available only in the combined form. You've got patches of various strength, as you see, ranging from 25 to 100. You can get the gel. You can get a new clip in the block is the spray. It's called the Lenceto spray, whereby the spray is applied every day. And it administers 1.53 milligrams per spray, and you can give up to 3 sprays per day. You can get the vaginal tablets. It's not very popular. There is the vaginal ring. Again, I've never prescribed the vaginal ring, but that's available. And then you've got the 50 milligram implant. The vaginal estrogens are available in these strengths. And then you've got the conjugated estrogens available in the 0.3, 0.625, and 1.25 strengths. Now, what are the side effects of estrogens? It's breast tenderness, leg cramps, headaches, nausea. And as I referred to before, if you find that somebody is having side effects, then clearly you need to change or reduce the dosage of the estrogens. And the progesterone-related problems are that of bleeding, PMS-like symptoms, headaches, and feeling bloated. Again, the solution to that would be changing from a C21, if you're already giving them a C20 or C19, to change it to a 21 and vice versa, and see how they will, how they feel with the different preparation. Now, testosterone is perfectly safe to give in recommended dose, and it's 5 milligrams per day transdermally. At the moment, correct me if I'm wrong, it is considered to be initiated in the secondary care, and the GPs can continue with it. But I think there is a move to empower GPs to give testosterone for the reasons that I'm going to come below. It's effective in low sexual desire. Psychosexual causes have been eliminated. Now, it is thought that the blood level needs to be checked initially to obtain a baseline level, and it's also recommended to check the level at 3 months. Clearly, I'm not particularly would support that, because initially, yes, you could check a blood level to see if it is very high before you start the testosterone, but the level of testosterone is not an accurate reflection of the libido, because of if you're giving estrogens as well with testosterone, then even if they have a normal level of testosterone, the effect will be not as good. And equally, sometimes you can have side effects which are higher with normal testosterone levels. So it's not a very accurate way of finding out if you're giving a patient adequate testosterone, but want of anything else, we have no other choice but to just get some sort of an objective evidence. The side effects with testosterone are very, very minimal. It can be acne, clitoral enlargement, or deepening of voice. All of them are reversible, and they can only occur with very, very high doses of testosterone. So therefore, really, there's no need for any scare to continue with testosterone. And the patients will easily acknowledge that they have any of these side effects if they're counseled about the side effects. The only problem is the deepening of the voice is probably the only irreversible side effect of testosterone, but one has to take loads of it before they actually manifest with this deepening of voice. Now, in all fairness, I've never ever come across a side effect of testosterone unless only in one patient, but that's because she had a testosterone-releasing tumor, and she never knew about this testosterone-releasing tumor. I mean, actually, she presented to the ENT with a deepening of voice, and when investigations were conducted, she actually had a testosterone-producing ovarian tumor, which was what was causing her all the problems. And once it was removed, that's the only side effect, that's the only thing that never got reversed. Now, if the patient is given testosterone and you're not able to get the desired response, it's probably not what she needs. So you can stop it. And obviously there's something else that one has to investigate as to why she's having reduced sexual desire. Now, clearly, there is a myth, and if you go to Dr. Google, there is some information that testosterone improves this mojo. That's what some of the ladies come and tell me. Somebody told me my mojo will be high if I have some testosterone. It's the evidence that it will improve muscle strength and cognitive function, mood, and energy are not proven. So ospemifene is a serum selective estrogen receptor modulator. I have prescribed this to one patient so far. So next is the prasterone. That's another medication that is available in the market. It is a dihydroepiandrostenedione, and it's available in the form of intravaginal pessary, and it's for vulvovaginal atrophy. Now, I have not used it, but it is available, and probably it's something that maybe in the secondary care it needs to be initiated. And this is for obviously refractory vulvovaginal problems. And it's contraindicated in unexplained bleeding and breast cancer. Now, I'm sure a lot of patients are worried about the risk of breast cancer should they take HRT, and equally the healthcare professionals have to counsel them appropriately. Now, what the good news is, as of now, the evidence has clearly shown that there's only a very small increase of risk of breast cancer with combined HRT. And in the pack that I have actually distributed, it outlines very nicely, very pictoriously as to how much the effect of HRT is there on breast cancer compared to obesity, compared to smoking, compared to alcohol, and therefore it's very easily can be explained to patients as to how much they will be affected should they have other lifestyle measures which can be modified for them to reduce the risk of breast cancer as opposed to just taking HRT. Now, with estrogen-only HRT, there's very little or no increase at all. So that's very good to note. Now, the risk of breast cancer is higher in women not on HRT if they take 2 units of alcohol every night. Risk of breast cancer is higher in women who are not on HRT or overweight with a BMI of over 30. HRT is not contraindicated in women with a family history of breast cancer because many women are often referred because they've got a family history of breast cancer and with menopausal symptoms to see what we can do for them. And HRT is not contraindicated in women who have got the BRCA gene mutation, definitely not up until the age of 51, especially if they've had prophylactic oophorectomy and they have got debilitating menopausal symptoms. It's perfectly reasonable to give them HRT. So the only contraindication to HRT is active estrogen-dependent cancer or active venous thromboembolism. So really, it's quite simple, and everybody can give anybody HRT as long as they don't have active estrogen-dependent cancer or active venous thromboembolism or extremely other confounding reasons why they would get other cancers like extreme obesity or something, and then they make their own choices to avoid HRT. Now, migraine with or without aura is not a contraindication. Again, that is often a myth that I have to dispel among many junior doctors who, and in fact, even my consultant colleagues. HRT can be considered an estrogen receptor negative breast cancer. So I've got about 3 patients who are on HRT who have had treatment for breast cancer, but they were estrogen negative. I mean, this is obviously, we have had a discussion with multidisciplinary meeting with their oncologists. Now, family history of DVT is not a contraindication, and in fact, a personal history of DVT in the past is not a contraindication either, as long as we give them a transdermal route of HRT. Now, HRT monitoring is generally considered to be at 3 months just to see if the medications or the interventions that we have employed is effective for them or not. So that's a good time frame for its efficacy. And then once if they're happy with the interventions, then they can be monitored annually and medications given. The same medications given, carried on. Now, what I would like to go through is the menopause standards by the British Menopause Society. And I'm just going to go through each one. So in women who are aged over 45 with menopausal symptoms, diagnosis for menopause need not be by taking any blood tests. So if they definitely have got menopausal symptoms and we have excluded other causes for their symptoms and we feel that it is menopausal, then clearly they can be given HRT. As I just wanted to reiterate, if they are still having periods, to be given cyclical. If they have no periods or if the last period was a year before that, then you can give them continuous. And if they do not have, obviously, if they don't have a uterus, then you can give them the estrogen only HRT. All women should be educated to access accurate advice and optimize their menopause transition. So these are the websites that you can signpost them and from where they can get a lot of patient information and make their own choice about HRT. Now, women over 45 with menopausal symptoms should be offered treatment after information and support and informed decision about management. And at the same time, there should be an opportunity to discuss alternative treatments and non-hormonal options as well. Women with genitourinary symptoms should be offered vaginal estrogens, and they can continue this as long as they require. I've already referred to this once. The progesterones are not required for this, and these can be prescribed for women who have had previous history of CA breast. Once HRT is commenced, a 3-month review is required, followed by annual review at least should be offered. And clearly, as I was going through the history of HRT, in the 2000, just before 2010, the advice was to give them the lowest dose for the shortest period of time, but that has changed. There's no limits to be placed on the dose of HRT, duration of usage for women who are taking treatment, as long as they are happy to continue with it and they have symptom relief. If HRT with adequate estrogen has not been effective, testosterone supplementation can be considered for women who have got low sexual desire. So the threshold to start testosterone has really gone down. And clearly, as long as I said, if you've excluded any psychosexual problems for their low sexual desire, then they can be given testosterone supplementation. And premature menopause has to be diagnosed after checking FSH. And premature menopause is considered to be before the age of 40. So if patient has got menopausal symptoms or absent periods before the age of 40, then FSH is required. It's also required in early menopause, which is menopause before 45 years of age. So between 40 and 45 years of age. Women with premature menopause should be given HRT at least until the natural age of menopause. Now, at this point, I would like to say that if you ever consider somebody who has got premature menopause and you feel that the patient has got menopausal symptoms, probably it's prudent to refer them on to the secondary care to at least initiate the HRT rather than taking that decision in the primary care. That's probably one cohort of patients who there is an indication for you to refer to the secondary care. Now, women with early menopause need FSH levels checked for diagnosis at least 4 to 6 weeks apart and HRT given at least until the natural age of menopause. Now, referral to a specialist, which I'm sure this is a slide that you're probably waiting for all this while. Menopause services should be considered, and menopause specialist input is required in the following points. Unable to achieve satisfactory symptom control despite all the interventions. Unscheduled bleeding over 6 months. Premature ovarian failure, where early menopause diagnosis is inconclusive. Women with complex medical backgrounds such as breast cancer, or if they have got other risks which would increase their thromboembolic episodes, and women with genitourinary symptoms with no relief from vaginal estrogens. Now, prescribable alternatives to HRT is quite important because you might end up having a good cohort of patients who are not happy to take HRT or in whom HRT is contraindicated. So these are the list of medications that are quite helpful. Gabapentin in the dose of 900 milligrams daily. It also improves quality of sleep. Pregabalin, which is can be given in divided doses, anything starting from 50 up to 300. It improves quality of life and antidepressant, and it's also an antidepressant. Clonidine is quite good in this dosage between 25 to 50 BD, and you can give a maximum of 75 micrograms BD or 50 micrograms 3 times a day. Now, SSRIs are good. However, you need to avoid sertraline, fluoxetine, and paroxetine in women who take tamoxifen, but you can give citalopram safely. Venlafaxine is quite good. I've got a couple of breast cancer patients who I've given venlafaxine and they had some symptom relief with that. And that is given in the dose between 37.5 to 150. So you slow titration is the safest choice. And this is the best for patients who are already on tamoxifen. I thought just the top 10 tips from for primary care, and this is obviously from the guidance from the British Menopause Society. So it's there in the pack for you. So I'll just kind of go through this. So it's kind of a recap of all the information that we have heard so far. Basically, it says all women should be able to access advice on how they can optimize their menopause transition and be able to meet a professional who can give an individualized approach after assessing their symptoms. Women who are over 45 years and over should have, with the diagnosis of perimenopause or menopause, should be considered based on their symptoms without having to go through any blood tests. Then HRT should be offered as a first-line treatment for symptoms, including vasomotor symptoms, problems with mood, anxiety, after discussing the short-term and longer-term benefits of HRT. Then decision whether to take HRT dose and duration should be again on an individual basis after having discussed all the risks and also explaining to them that HRT has got some cardiovascular and bone strengthening benefits, and there is no arbitrary time frame for when HRT can be given. They can have it for as long as they want. My oldest patient is 72 years of age. Now, estrogen alone HRT is associated with little or no change in the risk of breast cancer, while combined HRT can be associated with a slightly increased risk. However, the risk is low in terms of medical and statistical terms, and clearly it is more if one takes alcohol or is obese and smokes. Transdermal is better than oral should there is an increased risk of venous thromboembolism, and especially in women who have got a high BMI. Vaginal estrogen should be offered to women with urogenital atrophy, and treatment continued for as long as possible to relieve symptoms. Now, if HRT with adequate estrogen intake has not been effective, then testosterone supplementation can be considered in menopause after counseling. Women with premature ovarian insufficiency and early menopause should be advised to continue HRT until at least the age of their destined age of menopause. And clearly this is a criteria where a specialist menopause service is required and referral is indicated, where treatments do not improve menopausal symptoms, ongoing troublesome side effects, contraindication to HRT, and where there is uncertainty about the most suitable treatment option for the menopausal symptoms for the lady. And coming to the resources, there's a British Menopause website and the NICE guidelines. These are very good resources for you to look at and add more information to this talk, and also the additional information that I have given in your pack. Go through each question. First one is, does HRT have any impact on the regularity or irregularity of PV bleeding in perimenopausal women? Now, clearly, once you give them cyclical HRT, it is expected that they will get a bleed during when they're supposed to get a bleed when you take a break or at the end of that. So it should be more regular, I would think, provided if one has excluded any other causes for irregularity like polyps or any endometrial hyperplasia, then it should be more regular once you give them HRT. Next question is, does HRT have any impact on the age of natural menopause when used in perimenopausal women? It does not have any effect because it doesn't particularly affect the ovarian ovulation. Basically, what it is that the ovaries have stopped producing hormones. So the age does not get altered. Then what about Femostan as an alternative to TD? in those with elevated BMI, transdermal, isn't it? Now, just remind me, what does Femostan contain? Does anybody, can you remember? I can't remember offhand. Femostan in as an alternative to transdermal in those with elevated BMI. Femostan is got the more favorable progesterone as far as I can see, but clearly transdermal route is any day preferred to Femostan. I'm not aware of this this particular evidence. I'll have to look up that whether the Femostan over transdermal HRT, because Femostan has got a favorable progesterone, and in the transdermal it is obviously the levonorgestrel. So maybe, but I suppose I'll have to look up that evidence. I don't know. The Primary Care Women's Health website and Facebook were also superb resource. Okay, that's good. Do you increase the dose of progesterone when on maximum estrogen dose? Right. Okay, so if you've got a Mirena coil in, that's fine, because you can actually not worry about, you can increase the estrogen to how much ever you want. Now, clearly, when you say maximum estrogen dose, I'm not entirely sure what you mean by that. This is over and above the recommended dose is what I would think. If they're going over and above the recommended dose, yes, you have to increase the progesterone based on how much you have increased. So in small increments would be beneficial. So it'll heavily depend upon if you're going over the above recommended dose. So that would be an individual decision. I couldn't say what is the increase in progesterone that you have to give when you increase estrogen. In the recommended maximum is dose, it's fine to give the, obviously the recommend based on what is in the combined pill would be, combined HRT would be fine. Now, I would say that the risk of irregular bleeding is the main reason that perimenopausal women should have cyclical rather than continuous HRT. Yes, I agree to that. I haven't received the pack. Would you be able to send this again, please? It is actually, I have sent it to a lady called Amy, so she should be able to send it to you. I don't know, do they access it themselves or do they get it via email, Elise?
Yeah, we'll email it out to everybody afterwards, if that's okay, everyone. We'll email it out when we send out the feedback forms as well. We'll put it all together. Is that okay?
Yeah. Please, could you clarify the dosing of micronized progesterone in perimenopausal women alongside transdermal estrogen? Are they okay to take this continuously? So in perimenopausal women, the micronized progesterone dose is 200 milligrams, 12 days on, 16 days off, and they get a bleed in the 16-day period. Now, having said that, one thing which I forgot to actually mention is micronized progesterone or utrogestan has got an anxiolytic effect. It's also supposed to help with sleep. So most women will like to take it continuously. It's not recommended in perimenopausal, in premenopausal women. So in the ideal world, they should take it for 12 days on and 16 days off. And therefore, however, there is a lady who I have who takes a higher dose for 12 days and a slightly lower dose on the rest of the 16 days. So that's not a licensed way of or recommended way of giving utrogestan. What are your thoughts on starting HRT for the first time in women 70 years and over, given the associated risks that may be increased in this age group? Now, there is no, as I said, no age where you can deny them HRT. As long as the patient accepts the risks associated with HRT, they can be given. So if she's got an increased risk of I'm not sure what exactly the risk that you're talking, if she's obese or whether she's got other conditions, but there is no contraindication to initiate HRT at whichever age group, provided the patient accepts the risks. When should you switch someone from cyclical to continuous HRT? The average age of menopause in the UK is considered to be 51, and therefore 51 would be the age where you switch from cyclical to continuous. Clearly, if they do have irregular bleeding whilst on the continuous HRT beyond 6 months, then they need a endometrial biopsy.
Thank you for giving up your time for us. We all really appreciate it. We will send out the feedback form. So if everyone can fill them in, that'd be lovely, because then we can send Miss Matthew all our feedback, and I'm sure you can use that in your portfolio and things. So that would be kind of us all. And then we'll also send everybody a certificate. So
and
I'd
like to draw your attention to the pack that is sent. It's quite simple. It is from the British Menopause website, but only the members can access it. That's why I sent it separately, and it's quite good. It's simple and it's very easy to show the patients as well. The some of the flow charts.
That's so useful, because then then you can have a more in-depth conversation, can't you, when you've got something to just show them. And simple is perfect for me. So thank you. So I did just put on the first slide, but just to let everybody know, our next session is 8th of February on the Wednesday, and it's a hand session. So again, it should be really, really good.